All right, guys. My name is Travis Burns. Today I'm going to talk to you about white line disease. So I guess the first thing, can everybody hear me? Sounds good. Doesn't echo too much. Okay. All right. So I'm going to talk to you guys today about white line disease. And so before you talk about treating it or doing anything for it, first and foremost, you want to be able to define it or describe it. So anybody want to yell out what is white line disease? Anybody? I'd rather make this as interactive as you'd like, but I can also just stand and talk for 50 minutes if you'd like. Yeah. Jimmy, is that you answering back there? Yell it out. Okay. All right. So Jimmy says it's a disease process of these opportunistic microbes that affect specifically the strata medium of the horse's hoof wall. I would say very specifically the non-pigmented strata medium. So when you go back, it was first described by Dr. Redden, or first defined by Dr. Redden in 1990. So white line disease is a keratinolytic condition observed in the solar aspect of the horse's hoof, characterized by a progressive separation between the inner zone of the hoof wall. Okay, and so again, there's a lot of big words in there. So keratinolytic means it basically just degrades the keratin of the hoof wall. It's a self-exacerbating problem, and it creates this separation within the hoof wall that is chronic and progressive. Okay, so similar condition was described in cattle in 1980. Other terms for it, we've all heard them. We've all probably used them. Everything from seedy toe, hollow wall, the onychomycosis. All those terms are all referring to white line disease. Okay. Okay, and so specifically while we talk about white line disease, we'd like to talk about the anatomy of the horse's hoof wall. So when you look at this guy, obviously this is just a drawing of the bottom of a horse's foot. So if you take just that little sample from the wall itself and blow it up to where you can see it, you can see that the hoof wall actually has three different layers. You've got a stratum externum, and then you have pigmented stratum medium, non-pigmented stratum medium, and then the stratum lamellae are ultimately just the lamellar interface. So you have epidermal lamellae that interdigitate with dermal lamellae. Okay, and so when we talk about white line disease, again here in the U.S., what is the white line? What do we call the white line? What is that structure? Anybody? Just want to yell it out. Okay, so it's the epidermal lamellae that have grown down beyond the distal margin of the distal phalanx and attached with the sole. So they're the junction. It's a bond. And so very specifically when we talk about white line disease, we're talking about a disease process that affects kind of the white zone or the non-pigmented strata medium. It doesn't actually affect the horse's white line. So it is a bit of a misnomer. Okay, so we'll show you some examples. Again, this is just a specimen here, so you can see the different layers of the hoof wall. So this is all just bulk strata medium. This is all pigmented strata medium, very specifically non-pigmented strata medium. This is lamellar interface, or what would turn into the white line as you go distally, and then we have dermis and the horse's distal phalanx. Okay, so when we talk about white line disease, this is very characteristic of where I live and where we practice. Does foot look familiar to anybody else? You guys see a lot of this? Okay, and so very specifically, you see all these small separations or these lesions, whatever you want to call them, that are all packed with dirt and debris. Can everybody appreciate how I know it's a white foot, but I hope that everybody can see how very specifically it attacks that bright white zone, or ultimately the non-pigmented strata medium. Okay, and so that's going to come in to be very, very important when you talk about treatment and ultimately talking about debridement. Okay, so how you can treat it and debride or remove hoof wall without messing with the vascular system or causing blood to be exposed or harming the dermis. Okay, so what would happen if dirt and debris did pack into the white line and go proximal? Okay, so those are the ones that turn into abscesses. So when you see like this little guy right here, I don't know if anybody, I seem to be very shaky, but that particular area, right in here in the white line, or in that yellow dirt and debris pack into there and reach the dermis. That's how you have have abscesses. Okay, so that's the big difference. And so if you go just a millimeter abaxially and dirt and debris packs into the non-pigmented stratum medium, that's how you get white line disease. Okay, or that's the area that is affected. Okay, and so again, just to kind of show you some more examples of very classic white line disease that we get and see, ultimately results in these little small proximo-distal dorsal hoof wall cracks. This is what it looks like from the outside. That's what it looks like from the bottom. So you can see the big separation. You can hit it with a hammer, percuss it with your hoof testers, flick it with your finger, and you can hear that hollow sound. So that's where the term hollow wall comes from. Okay, so it does make a chronic, progressive separation there. Okay, so here, if you take one of those specimens, again, like on the outside here, if you just cut this right through it, you can see portions of the outer wall look normal. This guy obviously has the two cracks on either side. This guy would have just had a small crack on the outside, but you can see how the outer wall would be intact, and then you can see the dirt and debris that fill those areas or fill that separation. So it's this self-exacerbating problem with the microbes that cause the degradation or destruction to the horse's hoof wall, and then you have these dirt and debris that pack in there and act as a wedge and just keep forcing it apart, keep weakening things. Okay? And so again, if we were to talk about, I guess, the principles of treatment, which we're going to get into, I hope that you remember this picture. Okay? So again, a lot of people will talk to their clients, or a lot of farriers will go about this by just trying to pick that dirt and debris out of that area, or scoop it out with, curettes or dental picks or hoof picks or anything, and then just dump a whole bunch of chemicals or a whole bunch of the things that you guys saw in the trade show to try to treat it. But obviously, just dumping some sort of antiseptic in there, you're ultimately just treating dirt, when in all actuality, this is where you would like to get the antiseptic products or the stuff that you're treating with. You would like to get all the way up to here. Okay, so we're not going to talk about it just yet, but when we get to the point of talking about treatment and what is occurring, I hope that you keep this image just burned into your mind. Okay, and it'll give you the answer as to the primary principle of treating. Okay, so then if you were to take a radiograph of it, so this is obviously just a lateral to medial radiograph centered at the distal margin of the distal phalanx and the widest point of the horse's hoof. Okay, and so obviously we've got our normal anatomy. You've got P1, P2, the distal phalanx. You've got the hoof capsule, and then here you can see the little separation. Okay, and so oftentimes white line disease is first noticed by the farrier itself, which we take care of it at routine trimmings, just like that first white foot, the little kind of square-shaped foot with all the little lesions. That's very common, right? We see those all the time. We might debride them lightly. We trim them. We do all the things to them. But at some point when they continue to go or become refractory to normal debridement or normal routine farrier maintenance, it's often indicated or often very useful to employ a vet into the team, okay, for a multitude of reasons, from the sedation they can offer while you're debriding or treating or trying to shoe these things, to using radiographs to clearly show exactly the extent of it, to help discuss with the owner the debridement and what needs to happen. So I know it's not uncommon for white line disease cases to be handled just by farriers, but also remember that you can incorporate, and probably on a lot of cases or several cases, particularly ones that are unresponsive, you should ask or encourage the owner to allow you or to incorporate a vet into the team to help you. Okay? And they can help on many different fronts. Okay? So again, there are a multitude of proposed etiologies out there, as this described most recently by Moyer and O'Grady, and some of this came from Turner, is that it's probably some sort of combination between the environment. There may be some nutritional factors that play into it, mechanical factors or mechanical forces that are placed upon the horse's hoof capsule, and then it's thought that those things predispose or allow these opportunistic microbes to invade that area. And those little opportunistic microbes are thought and been shown to be keratinolytic lytic or keratinopathogenic, meaning that they do degrade the keratin of the horse's hoof wall. Okay? So if we just go through them individually, when we talk about the environments, we think, obviously white line disease is seen all over the country and ultimately probably a worldwide problem in certain areas. And so I'm not saying that you have to live in a wet, humid area that would, predispose a horse to white line disease. But it is thought that, it is more prevalent in wet or humid areas, and the way that these little opportunistic microbes invade would be basically just that cyclical phenomena from going from wet to dry, wet to dry, wet to dry, or just being wet all the time. It opens up the horse's hoof wall, like it will swell, it will allow for these opportunistic microbes to invade. In the dry, arid areas, it's thought that, having, really dry, hard ground and rocks and things basically cause these little lesions in the bottom of the horse's hoof, and then these opportunistic microbes are allowed to invade. Okay, and then I do think it is important to think, even if you don't live in one of these two environments, again, I do think that horse owners, trainers, grooms, whoever is managing the horse and bathing the horse, riding the horse gets all sweaty, first thing they want to do is just soak it down to cool it off, wash away the sweat, and then the feet are getting soaking wet. And then what's the next thing they do? They tend to put them right into like a perfectly clean, dry stall, so the foot goes from really, really wet to really, really dry, really, really quick. And that rapid cyclical phenomena is thought to be one of the predisposing factors to white line disease. Okay. Anybody else see a lot of white line disease in a different environment than one of these three? Nope. Nobody? All right. Okay. Some of the mechanical factors that are thought to predispose or allow the horse to succumb to white line disease would be chronic laminitis. So again, a malformed, misshapen dorsal hoof wall. The laminar wedge is obviously very similar to non-pigmented stratomedium, so it's often affected with these microbes. Flexural limb deformities. So again, the little clubfoot horse, just very similar to a chronic laminitic from the forces that are placed onto it. So the prying at the toe, those are thought to predispose a horse to white line disease. Flares, distortion, so allowing feet to become distorted, not trimming them on a routine cycle. All these things are thought to predispose a horse to white line disease or allow the horse to succumb to white line disease. And then it's been talked about and discussed a lot that the crina, or the shallow notch in the dorsodistal margin of the distal phalanx, predisposes a horse to white line disease. Okay, so we'll talk a little bit about it. And so O'Grady defines CD toe as a small circular separated area at the sole wall junction on the solar surface in the middle of the toe. Okay, so something that looks very similar to this. How many of us see this on a fairly regular basis? Okay, and so we all note and complain that area is very likely to succumb to white line disease. It's an area with a degraded, weak attachment. It does have this weak little flaky hoof wall. Okay, and then when you look at them, crap, I don't have a bottom picture, but it's not uncommon for when you see this on the bottom. What do you guys also see, like just the small little, maybe half-inch proximo-distal dorsal hoof wall crack right dead center at the toe? We see a lot of those things, right? And then there's, I'm sure I'll say it. Me personally, I've tried a lot of things to make that little thing go away, and in reality, not many of them really worked, right? Has anybody found a nice way to make them disappear? I'll admit, I've tried trimming them. I've tried putting natural balance on them. I set them back. I perimeter fit them, toe clip them, pack them, debride them, do all these things to them, and they always kind of come back or just stay the same, right? Okay, so it's thought one of my reasons or something that really bothered me and kind of pushed me to complete a project with a team at the vet school to clearly define, is there some sort of weakened attachment or something going on right there in the level of the crina that does predispose a horse to white line disease. Okay, and so when we look at, I know with the lights in here, it might be kind of hard to see that little shallow notch, but everybody in here knows what a crina is by now, right? Hopefully. Okay, so this small little notch, and so again, we did perform a small research project that did show there is, a marked aberration right there in the level of the crina, at basically very specifically at the lamellar attachment to the horse's hoof wall. Okay, and so there's a notch within the bone, but there's not a corresponding defect on the outer wall. So something has to fill that area. Okay. And so one of our small projects, again, we took, cadaver limb samples. We basically took, the horse's hoof and cut on either side, roughly, a centimeter and a half on either side of basically the apex of the frog. Okay? So centered it and cut on either side to have a nice specimen that looked like this. And then our aim was to get a specimen right through the crina itself and look at it histologically to see if there was a difference or a defect or specifically what was going on. Okay, so we took a bunch of cadaver limbs of horses that had crinas and did not have crinas, cut them, then cut a sample out of here that was roughly 3 to 5 millimeters thick. Okay, so we ended up with a little sample that looks like this. And so just to orient yourself, here's the distal phalanx, here's the lamellar interface, non-pigmented stratomedium, and hoof wall. Okay, and so here on the opposite side of it, you have the distal phalanx, the dermis, again the solar dermis, and then sole itself. Okay, so these are the samples we used to look at microscopically. And so again, the bulk of the horse's hoof wall would be removed with nippers. The bulk of the sole would be removed with nippers, and then we would put it in an eye cassette, fix it, give it to the histology technician, and she would stain it with this one specifically is Gomori's one-step trichrome. So she would stain it on a slide so we could look at it microscopically. Okay, so this is a relatively normal lamellar hoof wall sample. So again, just to orient yourself, this trichrome staining will take everything collagen-based and stain it blue, everything keratin-based and stain it red. Okay, so just to orient yourself here, again, out here you would have the horse's hoof wall. Okay, so this is non-pigmented stratomedium. Here's the lamellar interface. Here's dermis. That's a little piece of bone, dermis again, and sole. Okay, so that's what it looks like on a slide. And then as you start to zoom in onto it with a microscope, this is what you start to see. So again, you've got nice hoof wall out here, a beautiful lamellar interface, dermis covering the distal phalanx, solar dermis, and then sole. Okay, and so this is a normal, healthy horse's hoof. This is one that doesn't have a crina. Okay, so this is right through the same area of a distal phalanx with no crina. Nice, beautiful, normal, oriented, healthy attachment, right? Okay, so this is one with a crina. So obviously, hopefully, everybody can look at that very quickly and see the marked defect or the marked change or difference between the other slide. Okay, so again, to orient yourself, hoof wall would be up here. This is the lamellar interface. That's bone. Here's the crina. Okay, and so then you've got dermis again, and then sole. Okay, and so again, this whole area is abnormal. So the lamellar interface changes quite a bit as it comes in, and then right in the specific margin of the crina itself, there are no visible dermal lamellae, whether they be primary or secondary. Okay, there are no secondary epidermal lamellae. There are only elongated, irregular, deformed, distorted primary epidermal lamellae. There are no secondary epidermal lamellae there. Okay, and so it's thought that, again, if you were to hypothesize from there that leads it to basically having a weakened attachment, dirt and debris pack in there, succumbs to white line disease. Okay, and so also when you look at this big ball that sits right in there, it looks very, very much similar to sole itself and ultimately to non-pigmented stratomedium. So this obviously is abnormal. When you look at the structure of it, it looks very similar to this out here, which is non-pigmented stratomedium. So again, it's a simplistic view, but you could just look at it as just a big ball of non-pigmented stratomedium fills that area. Okay, and so it has to do it in a hurry. So the other portion of the non-pigmented stratomedium got to go all the way from the cornet to the ground. Okay, this one just had to get generated to fill that notch. Okay, and so we think it's a weakened area that is, predisposed or allows the horse to succumb to white line disease. Okay, so again, this is what they look like on the outside. And now you've seen what they look like on the inside. So there is, an anatomical problem there that I think predisposes the horse to white line disease in that particular area. But here you can see that small little proximo-distal dorsal hoof wall crack I talk about, and it's quite frustrating as a farrier. I'll admit I have several of these, and they do really bother me. Everybody else share the same issue? Happens a lot. Okay, so now you've got no answer as to how to make it go away, but maybe you have a little bit of an answer as to why it is there, why it does exist, why it's this constant, persistent little problem. Okay, so that's just a little quick thing on the crina itself. And then when you actually talk about the organisms or these opportunistic microbes that invade that area and ultimately are what we think causes white line disease itself, many organisms have been implicated. Most of them have been, actually fungi, not necessarily bacteria, and they're all thought to be anaerobic. Okay, so again, here's some fancy names that I'm not going to try to butcher in here. Okay, and then there was one study or one guy that did. Again, we had this idea as a nice research project, but then a guy has done it. He basically described a nice way to basically do the bulk of a debridement within the horse's hoof wall, try to sterilize it as best he could, and then try to take or culture basically the most proximal aspect of the white line separation or the white line disease separation, and try to culture it to identify what microbes were there. And again, all of those cases, again, it was only 5 of them, but they were all negative for a bacteria, and they showed up with these 4 fungi. So again, every disease process or anything that we do as farriers, I would encourage you all to think about just the principles of treatment. I think a lot of the conflict that occurs between farrier to farrier and vet to farrier all usually tends to be over very specific techniques. Okay, so every disease pathology I would give you, or every trimming shooting thing I want to do, I would describe to you first the principles that you would like to achieve. Okay, and so for white line disease, the principles you would like to achieve would be to reduce or limit the predisposing factors. So again, that means the mechanical lever, the prying on a clubfoot horse, a chronic laminitic, the long distorted, unhealthy hoof capsule, all of those things. We'd like to reduce any mechanical leverage that may have increased stress and strain in that area, allowing these opportunistic microbes to invade. Okay, so the lesions themselves, when they appear, I would encourage you, and it's certainly our philosophy, to debride to a healthy appearing margin. So obviously there's no way to get every little single microbe, but debride to as healthy appearing margin as you can with your eyes, and then treat it topically with any number of things. Okay, we'll go through some of those things, and then you would like to maintain the horse or the hoof in a clean and dry environment as best you can. And then the last principle would be to apply shoes with frog and sole support as needed. Okay, so we all have some small white line disease lesions that we debride to a healthy appearing margin, and they remain barefoot as those lesions get bigger. Running the risk of an unstable distal phalanx within the hoof capsule goes up. So I would encourage you to incorporate frog and sole support to help, limit distal displacement of the distal phalanx within the hoof capsule, or remove some of the stresses and strains on lamellar interface from having, missing portions of the horse's hoof wall. Okay, so those would be the principles, and then now we'll start to go through some specific techniques. Okay, and so again, the tools used for debridement, everybody probably uses different things for large areas of resections. We like to start with half round nippers. They allow you to bite into the outer hoof wall and remove it very, very rapidly. But obviously they should be used with marked caution, and they're really just used for big or large areas of resection. Okay, we use a lot of very small loop knives. Very specifically, the hoof knife we use the most is Ringle's nice little loop knife. But as you guys saw on the trade show today, there's hundreds of knives out there, but a small little loop knife allows you to have a lot of control to remove hoof wall in a very precise manner. Okay, and so again, you can have any different size of loop knives. So if you're doing big resections here, if you're trying to do smaller ones, smaller loop knives, so you can be very, very precise. Okay, so because again, when we talk about, like if we just look at those, well, it's probably too far to go back, but if you remember the anatomical structures, the non-pigmented stratomedium butts right up to the lamellar interface, and within the lamellar interface, there is, obviously a highly specialized vascular system that goes through there. So you're not very far from sensitive structures or hurting the horse. So, as you're getting to the deepest parts or the most affected parts of white line disease or the most sensitive, you are getting close to sensitive structures. So you should be very, very precise. Okay. So again, moving on to getting even more precise are these small little bone curettes that have, basically just small little melon ball scoops. So again, you can do very precise work with them. And then to be even more precise from there, we very commonly use these little carbide burrs that fit in the Dremel. Okay? And you can get these in a multitude of different sizes. And so this is blown up, but that little thing on the end is probably no bigger than that. It's a small thing that you can be very precise with. And what makes them unique, having these carbide burrs, is they actually cut hoof wall. So it will cut it and remove it and throw it out. Okay? Whereas a lot of the sanding burrs, the tungsten burrs, all of those things, they grind it away. Right? So it makes a powder right where you're trying to see, and it produces a lot of heat. This just cuts it away. Okay? So we use these all the time, from everything from white line disease to open abscesses to keratoma removal, resections, any number of things when you're trying to remove horse's hoof wall in a very precise manner. Okay? So if we just take a case with marked to severe white line disease, obviously you can see this one has been treated by a vet farrier team already. They've tried to do some of the dorsal hoof wall resections that are needed. They've tried to keep it clean. You can see some bandage material, but there's still a whole lot of dirt and debris and problems there. Okay, so obviously debridement is first and foremost. So simply we'll use those tools and start to remove affected areas, exposing all those areas to UV light and air, which ultimately kills all of those little microbes. So these are just different stages of the debridement. So you can see the big bulk from the top is removed. So all this got removed with a half round. Then we start to use knives to go after all these little areas, and then use the little sanding burr or the carbide burr to clean this area. Okay? And so that's a finished debridement to a pretty healthy appearing margin. Okay, and you can see there's very little damage to anything sensitive. Of course, there's the one little micro hemorrhage right there to ruin the picture. But ideally, you shouldn't have any of that. Okay, so true white line disease, it should be axial to sensitive structures. So you should be able to debride it to a fairly healthy appearing margin without really disrupting any of the sensitive structures within the horse's hoof caps. Yep, Chris, you got a question? Okay, so the question is, after we remove all this area, what do we do with it to keep it clean and dry? So that just happens to be where we're going. Okay, and so again, if we just go through the principles of treatment, the first is to debride to a healthy appearing margin. Number two is to treat topically. And so in this picture, that area was treated topically with 7% tincture of iodine, but you could treat it topically with any number of things, from thrush buster to, hell, I don't know, I just got something new today that I'd never seen. You could probably use this handy dandy groom's hand. Anything, any of those topical antiseptics probably all work very well after you've debrided to a healthy appearing margin. None of those things are going to work very well in that picture I showed you with that sagittal cut, and you saw that big ball of dirt and debris. You can't dump enough stuff in there to keep it clean. Yes, ma'am. Okay, so the question is, do I see it go higher than this? Have I ever seen it go all the way to the coronary band? And I would say, yeah, I've seen them go higher than this. And this particular horse, unfortunately, also had an abscess, so you can see where it broke out here. So it's separated all the way up through there. And so we left that little piece at the top to be a bridge. But if you were to truly debride this one all the way, that would come off too. But then you would have ultimately 2 halves of a horse's hoof capsule. So we made the conscious decision to leave it as a little bridge. Okay. So again, principles of treatment: treat it topically. With any number of things. Copper sulfate solutions, whatever you want to treat it with. If you debride to a healthy appearing margin, all those things probably work very, very well. This is just our preferred method. Okay. It dries, hardens, and then it does act as a bit of a dye marker, so it'll show you still the affected areas, or the most deep areas, I guess, for a lack of better words, most axial areas. But there you can see that when I talk about that clear abscess breaking out. So this little guy is separated all the way through there, and it did drain all the way through there. Okay. So that little guy, to answer your question, Chris, it's very difficult at that point to safely and securely attach a shoe of any kind, right? Nobody really wants to be nailing to that little nub. And again, I'm going to talk about some ways to glue them and glue around them, but again, party line and what care or caution should be utilized. You should never just be sticking adhesive over anything that looks like this. Okay, don't be confused when I talk about glue later on as trying to fill that area. Don't put glue over any of those areas. Okay, so we're going to treat topically. This one obviously couldn't live in a shoe, or we didn't feel we had the ability to safely and securely attach a shoe, so we chose to bandage it to keep it clean and dry, and then stick it in a soft ride boot. Okay, yes, sir. I'm sorry. No, it's basically just that we flooded it with tincture of iodine, and then again I can't remember the details if we put 4x4s in there, if it's just literally just covered. It probably just has conform and vet wrap, but it does have that bulge, so it might have 4x4s in there. But either way, we didn't really put anything on or over that area other than the tincture of iodine. Okay, and so the question is, would you put any sort of breathe hole? And so again, the conform and vet wrap allow for an oxygen exchange. Okay, and so covering that area with something that would not allow that probably would not be a good idea. And even the boot itself, very specifically, we utilized a soft ride boot for frog and sole support and to add depth just to make the horse comfortable. But also soft ride was chosen because it is a more breathable boot. It does have those openings, but the boot that maybe wouldn't be the best for you might be, what's the old plastic rubbery one? The Davis boot. Yeah. No, that one may not be your best choice for that. If that's all you got, sure. But again, to go back to like the breathe hole, again, that one principle is to allow UV light and air to it is important. So when it's bandaged, obviously the light isn't getting to it, but air should be getting to it, and then that should be changed daily or every other day, and then the owner would treat topically every day. Brush it out, keep it clean, and keep treating topically until it does grow out. So it is a lot of work for the owner. A lot should go into that. It's not just bandaged up and kicked out. Okay, and then I would encourage everybody. Everybody went to Dr. Van Epps' talk this morning, and he talked a lot about support limb laminitis. Again, you would be remiss not to incorporate frog and sole support in the other limb. If this one's affected to that degree, and you think there might be an unstable distal phalanx within the hoof capsule, why not shoe the other foot and try to incorporate frog and sole support to help it? So again, it's easy to just focus on the one affected limb, but remember there are always 4 other feet or 3 other feet. Okay, so again, back to smaller things. Of course, the one I showed you, that's a very severe white line disease. Okay, this is far more common. We have the small little area that's debrided to a healthy appearing margin, and then from there you can do any number of things. So you can attach a shoe if you want to. You can attach a shoe with frog and sole support if you want to. You could leave it barefoot. You could do any number of things, right? But the principles are still going to be the same. It's open, it's exposed to UV light and air. It'll be kept clean, treated topically, and then if you decide to shoe it, you could do any number of things. You know, if you're worried about it, stabilizing it on either side, you could stabilize it with clips. You could glue a metal bar over it. You could do any number of things if you think the hoof capsule needs to be stabilized. Okay, but most specifically, we leave it open to UV light and air if it can be maintained in a relatively clean and dry environment. Okay, so even bigger areas of resection, sometimes we leave them open to UV light and air, but it's not uncommon. You know, some of them it's easy to safely and securely attach a shoe with nails. Some of them you have to get creative and attach a shoe with a glue on, but again, very specifically not putting glue over the affected area. So this one specifically is just a Sound Horse Series 1 shoe with all of that area cut out. The fabric's just been removed. Okay? And then so it's glued on, attached in the heel on both sides. Okay, that could be done. And then again, if you can leave it exposed to UV light and air, and the owner can keep it in a clean and dry environment, that's probably ideal. So they can brush it out, clean it, and treat it every single day. Okay? If they can't provide a clean, dry environment, then you have to come up with something else. Okay, so it's not uncommon where we live and our clients for feet to come back looking like this. So obviously this area that was debrided and exposed, you know, isn't being maintained in a clean, dry environment. It's just being covered with dirt, debris, all these little microbes. It's staying in a moist area. It's just covered in mud. So again, if the owner simply can't maintain it in a clean, dry state, then to get around that, we've gotten a little creative to basically essentially provide our own environment or create a long-term bandage, for lack of a better analogy. So again, here, this particular example, we've got white line disease affecting whatever this is, the lateral quarter here on this little guy. So it's obviously been debrided, it's been treated topically. You know, it was probably bandaged for a couple days, so it could be treated topically daily. Okay, and then we take, you know, obviously you have that defect. So something, you've got to do something if you're going to make it a long-term bandage or make it, you know, I guess refractory is probably the wrong word, but if you make it or put it in an environment to where you don't have to worry about the outside environments affecting that area. So one of the things we do is take any of the impression materials that are out there. They're just 2-part silicones mixed together, roughly equal amounts, mix them together till you have nice one uniform color, fill the defect, basically fill it and make an insert that matches everything that you just pulled away. So you're left with, you know, a nice perfect little shape. Okay? So you fill in everything you just took away with impression material. Okay? Allow it to set up, and then we use you know, any of the polymethyl methacrylates out there. So we personally prefer Equilox, but any of them could be used, and then we pick a repair fabric. So could be any of them out there, from fiberglass to polyvectran to Cobra Sox to Spectra, whatever you want to build it out of. Okay, so get yourself a repair fabric. Again, for this specific example, we're going to use 4-inch wide polyvectran. Okay, basically put it over the horse's hoof, trace it, and cut out, you know, several layers to cover that area or to replace what got removed. So we use, in this particular case, we're going to use 2 layers of it. Okay, we're going to mix together our polymethyl methacrylate. You know, the foot, I guess, again, you're gluing to the horse's hoof, and so I didn't go through all the things you have to do to prep a foot for glue, but it's got to be prepped, it's got to be clean, it's got to be ready to accept the adhesive. So we mix up the adhesive, saturate all layers of that fabric, stack them together, press them flat with, you know, this is an old paint roller, could be done with a can, anything. Just press it flat to remove all the excess glue, put it on the horse's hoof wall, over top of the impression material, wrap it up, and allow it to set up. Okay, so in 3 to 5 minutes, you end up with something that looks like this. So it's rebuilt, it's sealed on the outside. Okay, so you know, it looks like normal hoof. It's ready for, you know, a shoe and a pad. But on the bottom of it, the beauty of using that impression material is it gives you the outer look. Okay, so it looks just like the old hoof wall, but the adhesive doesn't stick to impression material. Okay, so it's very easy just to pull out the impression material and you're left with a nice big crater. Okay, so again, you can see how this thing's been treated topically. It's been very well kept. Okay, and so then we're going to cover the bottom of the foot with venous turpentine, and then sprinkle copper sulfate all over it. So the copper sulfate's a broad antimicrobial. Okay? We use the venous turpentine just to make it sticky, so the crystals stick to it. And then you can fill this hole. You can put as much copper sulfate in there as you want. And then again, we're going to cover it with a shoe and a pad to make it a long-term bandage. And then the rest of the bottom of the horse's foot is going to be covered with a mix of oakum, venous turpentine, and copper sulfate. So we'll take the oakum, fluff it up, mince it up, mix it with venous turpentine or saturate it, and then sprinkle in a whole lot of copper sulfate. So there's no nice, perfect little formula. I just dump in whatever. If Dr. Pleasant's there, he dumps in twice as much. So just put a bunch of copper sulfate in it, and then you can pack the entire bottom or the entire solar surface of the hoof. So it's non-sealing, so you don't have to worry about it abscessing or exacerbating the white line disease problem, and it will keep all dirt and debris out of that area. And then we simply cover it with a shoe and a pad. And it just essentially acts as a long-term bandage. Does it make sense? Okay, and so when you come back, again, this is what you get. So when you come back, you pull off the little glue patch, you can see the packing material in it, and you can still see the old copper sulfate crystals. You don't see any dirt, debris, microbial activity. You don't see any degraded wall up above here. That peeled off as pretty as can be, right? So it allows you to basically put on a long-term bandage. So that's the exact same foot growing out, heels, nice, perfect, healthy. Okay? From the bottom, you can still see some little areas that, with white line disease, you are continually trying to debride or make sure you get to solid, healthy wall. Okay? But that's, again, the solar surface of that, grown out, nice and healthy. Okay? Just from doing that simple technique to make it a long-term bandage. Okay? Do we have time? Okay. And so, again, does anybody have any questions on any part of that? Yep. Scream it out. But I'm about half deaf. Yes, so the question is, what kind of shoe is that glued on over it? So, yes, that's just a normal Sound Horse Series 1 horseshoe, okay? Nope, I just glued straight over that little thing. So so the question is, did I cut or remove away the piece of fabric that went over there? And no, you just lightly sand that little repair and then just glue it on just like normal, okay? But you could nail one on there. You could direct glue one on there. You could do whatever. Just our preferred way was Sound Horse Series 1. Yes, sir. Okay, so the question is, would you ever consider leaving the impression material in the cavity? So taking copper sulfate, mixing it within the impression material, and leave it. Okay, and so I tell you, would you ever consider it? Yeah, absolutely. So I would consider it, and I would say, you just have to try it. So we've done it on a couple, and again, it does leach out of the silicone. It'll leach out and treat that area. It again, from just a rudimentary or anecdotal way of looking at it, when you come back and you pull that thing off and see what's filled into there, when you see all the green, it's definitely leaching out of that and goes into the horse's hoof wall. And so when we've done it just by leaving the impression material in there impregnated with copper sulfate, it doesn't appear to leach out as well. So again, you just got to try it on your own and what you want to do. And we probably are a little ultra conservative by the time they come to us. And so this is most likely, more often than not, we pull it out and pack it with the oakum venous turpentine, because it's been proven or shown to us repeatedly clinically that it does leach out very, very well. Yes, sir. What? Okay. So again, the question is, would I be opposed to running a torch over the debrided area before treating treating topically to dry it and harden it. And then again, to answer that question, me personally, no, we don't run a torch over that area. Oftentimes with the debridements or the cases we see, it's a extremely thin layer of, stratum medium or even portions of the epidermal lamellar interface that is covering that area. And so I personally wouldn't want to put heat on it. Specifically, you do want it to become dry. And so the biggest reason we prefer the 7% tincture of iodine is it does dry and harden that area very, very rapidly. So you saw how it got treated. It was just flooded and be liquidly, and then a minute later, it's that dry, hard appearance. And so these feet, when you start doing the resections, yeah, they're moist and nasty under there, but the longer it stands on your clean mats while you're doing the debridement, it's getting drier and drier and drier. So no, I personally don't torch them, but if you chose to, I would just do it with extreme caution. Yes, sir. Okay. Yep. So the question is, do you incorporate any sort of mechanics within the shoe itself to limit any of those leverages on the toe or the affected area? So again, remember, principle number one was, remove or limit the predisposing factors, which are often mechanical in nature. So yes, putting on shoes with rolled toes, rocker toes. Hopefully, I'm not going to be a liar, but that thing is rolled all the way to the inner edge. So sure, roll the toe, roll the edges, roll the heel, roll whatever you think might pry in the affected area that you are. So there's no doubt mechanical forces, in my mind, predispose certain portions of the horse's hoof wall to white line disease. Yes, ma'am. Okay, so the question is, have we tried actually putting UV light over those areas? I would say, me personally, no. I have no familiarity with, no experience at all. But. Any other questions? Yes, Dr. Ron. Mm-hmm. Yeah, so the question is, would I call, the area within the crenna, we saw that marked aberration right where the crenna is within the lamellar interface, the marked abnormality there. Would I consider that or call that a mild or baby laminitis? I guess I probably haven't really thought of it that way. Honestly, the way I think of it and do often wonder is it a baby keratoma? That's the question that always runs in my mind. Is there some sort of association with them? But I don't really have an answer. Yes, sir. Okay. Yep. Yeah. So if in the very mild cases of white line disease like that, the first one I showed you, that little square foot, those little mild things. The question is, have I noticed any of those responding well to either torching or hot shoeing or burning it on? And I mean, I'm just going to be honest with you. If I nail a shoe on, it gets hot fit. So I can't really compare to not hot fitting it. But no, I showed you a lot of pictures of extreme debridements or again, more moderate to severe cases. But that first foot, we deal with that all day, every day, and they're perfectly fine as long as the microbes or the disease process isn't traveling proximally faster than the hoof wall can grow. So if the hoof wall is growing fast enough, that just grows out and is trimmed away. And so we do all kinds of things to them, from trim them, debride those little areas, pack them with copper sulfate powder, pack them with the copper sulfate wax from Kinetic Vet, or burn it, torch it, treat it topically, and then put a shoe over it as a mechanical barrier. And then even if you want to go as far as to put a shoe and a pad over it to basically make yourself your own little long-term bandage. We do all those things. And the majority of those cases grow out and you don't have a problem. Of course, I'm going to show you the wild, crazy cases. Yes, sir. Mm-hmm. Mm-hmm. How do you handle it? So, yes. So the question is, the last remaining track or the deepest track and the most proximal track. The question is, how do we deal with that fear of going too far or moving too much? We all, or I'd say most of us, have a tendency to want to be a little conservative. Nobody woke up today and said, I'm just going to go out here and just see how bad we can hurt a horse. That's never been done, right? So we're all going to be a little conservative, and I do think, again, how do you deal with that? I would say being a part of a vet farrier team, or having 2 farriers there, or whatever, having another person to help coach and provide moral support. Let's just try a little more, and try to get it to as healthy appearing margin as you can safely is the first way that I would deal with it. But again, if you get uncomfortable, then of course you should stop. And a lot of the topical treatments will penetrate to the horse's hoof. It will penetrate, a couple millimeters into those tissues. So you don't have to go. Again, I know it sounds soul crushing to say, you don't have to go all the way, but you do have to debride almost all the way to a healthy appearing margin. But it should be as healthy appearing margin as you possibly can, and then allow your topical astringents to penetrate and kill the last remaining microbes. But when you are getting up near the coronary band, we all know that, just basic anatomy, there's the hoof wall gets thinner, the coronary cushion or the coronary dermis sits in there, the hoof wall kind of angles back out. So it does get very, very, very thin up at the top, and obviously if you go all the way top to bottom and resect it, then you have 2 halves of a hoof capsule, and you have to find a way to stabilize the horse's hoof capsule. Meaning you either have to rebuild it, or plate across it, or bridge both halves of the horse's hoof wall, and then incorporate frog and sole support. Did that answer the question? Kind of long-winded, but yes, ma'am. Mm-hmm. Yes, so the question is, the smaller debridements, or the little thing at the toe that was cut out and debrided, had clips on either side, could we rebuild it and do the same thing we did there in the quarter? Of course. And again, depending on the client, the discipline, the whatever, you may have to just do that just to make it relatively aesthetically, same everything. You just go through the exact same process. So that little plate or patch or whatever you want to call it, that can be done anywhere on the horse's hoof, and it can be done to any size you want. You can cut that fabric to match any portion of it, and it molds right to the hoof. You can rebuild it, make it look fairly loose term, but fairly normal. Yeah, no, for sure. So the statement is, you're almost better off to assume that the client is not going to be able to maintain it clean, dry, and healthy. They're probably not going to treat it topically as much as we want, and it may keep away some of the outer humidities and keep it refractory or unresponsive to the outside environments. Yeah, for sure. You can make that. I've got a ton of those clients. I'll admit, a lot of them we do have to patch or cover just to keep them clean, just to have a long-term bandage. Yep. Mm-hmm. So the question is, if we leave it open and exposed to UV light and air, and we're going to have the owner treat it topically, how often would that be? And I would say as often as they possibly can. So again, we encourage our clients to go to the hardware store, get the little wire brushes we use, the welding brushes, pick that area out, brush it, get it as clean as you possibly can, and treat it topically as often as you can. So particularly for us, if we're using the tincture of iodine, again, when they bring the horse in, stick it in a set of cross ties, pick it out, brush it, treat it topically, groom it, treat it topically, throw the saddle on, treat it topically, go ride, come back, brush it out, treat it topically. And it is often as they can, remove any of the dirt and debris, expose it to UV light and air, and treat it topically. But that being said, we do have clients that simply they can't do it daily, much less multiple times daily. Sometimes it's once a week, once every other week. It's whatever they can do is good. But obviously, I'm going to ask for daily until they tell me no, or they just don't do it. The question is, can you go too much? And I would say in my or our experience, no, you can't do too much on the outer hoof wall. That being said, the tincture of iodine and the thrush busters, those things are very caustic in nature. They should not be put on dermal tissues or sensitive tissues at all. So it very specifically just goes on epidermal tissue. You should not put it on anything else. So we encourage our owners, as they're putting it on, to paint it while it's on the ground, or if they pick up the foot in kind of a shoeing position and then treat topically, to put something over the cornet or the skin. They shouldn't be getting it on the cornet and the skin, and then ultimately, if you're using tincture of iodine, the owner shouldn't be getting it on to their skin every day. So we use syringes to do it. We put it in little plastic cups, take a paintbrush, paint it, do whatever you want, but it shouldn't go onto skin, and it definitely shouldn't go on to dermal tissues or sensitive tissues. Yes, ma'am. Yes. So the question is, do those little areas of white line disease become more prevalent with age, or ultimately with remodeling or shaping or changes within the distal phalanx? And I would say absolutely. Just like the crenna has that little defect, any other change within the distal phalanx itself that doesn't result in a corresponding defect within the horse's hoof has to fill in with something, and it fills in with the same tissues, the same things that I personally think predispose a horse to white line disease. So yes, as the bone changes, as the horses get older and their bones change, I do think it changes and predisposes them to it. Chronic laminitis, I really think that big lamellar wedge, that distortion, again, chronic laminitis, one of the biggest principles is trying to manage all the other secondary complications like white line disease and abscesses. Chronic laminitis are very predisposed to those two things. Any other questions? I think we got 1 minute. All right. Well, thank you all very much for coming and listening to me. I appreciate it.